breast cancer patients and breast cancer population. So to begin, it's nice to know about the basis and the history of oligometastatic disease. The oligometastatic disease theory has been established since 1894, when an original editorial was written discussing the theory of and the pathogenesis of oligometastatic disease. Later on, in 1995, there was a paper published in American Society of Clinical Oncology talking about something called local therapy directed for metastases, and is that going to improve the outcome of the disease? And you can see this is a screenshot from that editorial saying if there is any light of emerging information on the multi-step nature of cancer progression. And interestingly, this editorial was for the breast cancer population, not from the lung or any sites. So what is oligometastatic disease? Oligometastatic disease can be named for any isolated or limited metastatic disease. So you can see a metastatic disease, but it's limited or low burden disease. By ESMO, it was defined by a maximum of 5 metastatic lesions in the body. So there is no clear universal definition for oligometastatic disease. In the editorial, back in the 2 decades ago, they talk about oligometastasis without mentioning the condition of the primary tumor. So we can say oligometastasis even if the primary is not controlled, and we can say oligorecurrence if the primary is controlled. But our definition of oligometastasis, even in our established guidelines, is it's mandatory to have the primary diseases controlled, and there is a less than 5 metastatic sites. So the incidence of oligometastatic disease in breast cancer, this is a paper was published by Jane in 2012, and it was saying that the incidence of oligometastatic breast cancer is around 20%. This is an interesting paper published in last year, 2020, in ESMO, and you can see since 2 decades, the data has been growing and the evidence is evolving for the oligometastatic disease. Now they are talking about even the subtypes and is it synchronous or metachronous oligometastases. This paper showed that the oligometastasis breast cancers range from 20 to 50%. Synchronous about 15%. That means the patient presented with metastatic disease. And metachronous, that means the patient presented with the early stage. Most of them, 80%, was a stage 2 breast cancer. And down the road, they relapsed, and then you call it metachronous disease. 75% of them was luminal, and 5 years overall survival reached about 78%. We have our own data. This is an abstract, was published last year in 2020. And if we found that the oligometastatic breast cancer patient population is around 17%. This is a nice study just to go backward. In 2002, and they found that oligometastatic breast cancer patient, if they have lung metastases by England, and they found the median survival was 35 months, 15 years overall survival reached about 18%. This is a paper of 2002. This is another paper just recently published in February 2021 by Netherlands, and it's a cohort study, observational study showing the oligometastases in breast cancer population. And they found about 3,447 patients from 2000 to 2007, 10-year survival for those patients who had 3 metastatic sites reach about 14.9%. So that made the evidence to shift from palliative to potentially curative intent for this population, given the good prognosis and long-term survival of these patients. This is a SABRE COMET trial. It's a landmark trial, practice-changing in metastatic disease, SABRE COMET trial. I remember I was a resident since then, recruiting patients and randomizing them between a standard of care or SABRE arms, stereotactic ablative body radiotherapy. Actually, to be honest, it's the main thing and the main factor that most of the patients, we shift them to saber arm is having good performance status. It's not about the clinical or the staging of the disease itself. So they randomize the patient to palliative care, just go with palliation, or go with stereotactic ablative body radiotherapy. This is the early publication of the trial. They showed the median overall survival is 28 months in the standard of care arm, palliative arm, but it doubled for the patients who had saber technique. And it showed that the saber technique was safe with the toxicity doesn't exceed 29% with a significant p-value. The long-term outcome of this trial showed that there is an increase in 5-year-old survival for the patient from the standard of care 17% to 42% in the patient who had saber as a treatment for oligometastasis. And as you see, the major population of this saber comet trial was breast, lung, and colorectal cancer. So what is saber technique? It was usually stereotactic ablative body radiotherapy stands for precise delivery of high dose of radiation in 1 to 5 fractions, doesn't exceed 5 fractions, with a tumor ablation and maximum sparing of normal tissue. So let us talk about practical real cases of oligometastatic disease, and does it go on with evidence or not? This is a patient of our institution, known to several of our colleagues. She's a 32 years old female, presented early back in 2017 with the early breast cancer. Then she refused having surgery, and she went abroad to have another opinion. Unfortunately, she presented to our institution later on in October 2018 with lumbar metastases L234. And you can see here that the lesion is compressing the cauda equina with a fungating breast mass on the breast. So what we have done, we went over the metastatic L2, L3, L4 with stereotactic ablative body radiotherapy with a huge dose. And you can see here, you can see actually how the precise delivery of the radiation, and we've been able to preserve the spinal, the cauda equina, and part of the spinal cord up here at the level of L2. We treated the breast, as you know, and it's considered metastases, so the role of surgery is limited a bit. So went to standard radiation, and then we go with ablative dose, stereotactic ablative body radiotherapy to the persistent lesions. There is a risk about 30% of having the bone itself melt or fracture, and actually, later on in the follow-up in January 2019, she had a complete response in the lesion in the breast, and as you see in the PET CT for the lumbar spine metastases. It's been reported, as you can see here, that there is a fracture of the lumbar vertebrae. So it is expected, but luckily this is an weight bearing area. So she managed to walk again. She presented to clinic on a wheelchair. Now she's completely independent. Later on, in January 2020, she presented to the clinic complaining of back pain. So we did a PET CT and we found that there is a lesion on T5. So we did an MRI and we assessed the spinal cord tolerability to the stereotactic ablative body radiotherapy, and she had a stereotactic ablative dose to that T5 lesion. And later on in April 2020, you can see, and we confirmed the complete response of T5 lesions. And we labeled the patient that she had a complete response. Unfortunately, later on in February 2021, she presented what we call about a crisis. Just to emphasize that during all this period of time, she was on systemic treatment. So our team in medical oncology, they try to shift from and alternate from systemic treatment to another one, and doing alternative techniques. Initially, she was on hormonal treatment. Then when she progressed, they shift her to TDM1, and now she's on. When we found this crisis, we shifted our colleague shifted her to chemotherapy. So what we have done here, she presented again with 3 metastatic lesions: right ilium, left ischium, and left hilum. So what we have done again, we zapped the lesions on the right ileum and the left ischium with ablative doses. And regarding the left hilum, we try to contact our interventional radiologist to insert a landmark or fiducials so we can track the lesions using Sabernaf technique. But unfortunately, the challenging here when you treat the central mediastinum, you cannot put a marker or fiducials, so you can track the lesion using a saber knife. So we went with the classical technique using cone beam CT. This is a 4D cone beam CT, and you can see how is the range of tolerances of error of margin is 4 millimeter, 0.1, 1.5 millimeter, and 1.2 millimeter. We managed to treat her with 5 fractions to the left hilum as well. So this is the follow-up in April 2021. The patient was labeled no evidence of disease by April 2021. So you can imagine the story of her oligometastatic disease since 2018. So she's alive for 4 years now. This is another patient, so we can talk about not only the age factor. This is a 50-year-old female, presented again with oligometastatic breast cancer in 2018. So the pathogenesis is different from patient to patient. As you saw in the previous patient, most of the recurrence was extracranial, no brain metastases, and that would highlight things in our practical clinical experience. My personal belief that when the patient had the extracranial metastasis, a non-visceral metastasis, they do way better than the patient who had a visceral metastasis. And we will categorize these patients together at the end of the lecture, inshallah. So this patient had a brain relapse. So we treated so far 4 lesions on the brain: left parietum in 2018, right occipital in February 2020, right temporal, and then lately right cerebellar metastases. All of these lesions were treated with Sabernaf technique using stereotactic radiosurgery. Later on, at the mid of 2019, she presented with C3 lesion and T9 lesions. So I remember the patient saying one word in the clinic that, please do whatever it takes, I just need to be independent. She's a widow, she lives alone, she drives herself by a car, driving her own car back and forth from hospital, from home. So it means a lot then when the patient is encouraged to have a precise, aggressive technique just to hold on independency. So we treated C3 lesions and T9 lesions using, again, the Sabernaf technique. And she was labeled no evidence of disease just last month by using PET-CT. She's still alive. Interestingly, nowadays, the oligometastases, they are exploring even 10 metastases. This is a trial now, it's on recruitment. It was opened in August 2019. And the aim of this trial is to explore the long-term survival can be achieved for those patients who have 4 to 10 metastases. So now we have evidence saying that those patients who had less than 5 metastatic lesions, they do live way better by evidence than the patient who had no aggressive local treatment, either by surgery or stereotactic ablative body radiotherapy. Now they are exploring what about 4 to 10. And the benefit of this trial is either to go and cross the line or just to hold on 5 metastatic sites. So it will make a better identification and clarification of these oligometastatic population. So the take-home messages is, for oligometastatic breast cancer, the evidence is still evolving. It's recommended and better to identify and better selection of these kind of patients. We should go with the multidisciplinary team approach for those patients. Oligometastatic breast cancer, they worth an aggressive approach of treatment. We are talking about 10 years now. Of 10 years of 15% overall survival. The things that we need to identify is visceral and non-visceral. So again, extracranial bone metastases, which is the most common site of metastasis, they do way better, number 1 of outcome, followed by the patient who had a brain relapse, and the least patient who had not favorable outcome is the visceral metastases. And to be honest, when I have a patient with oligometastasis with a visceral metastasis, say liver or bone or abdomen, then I hold my horses a bit and I know that the outcome is not going to be as what when we have an extracranial metastases. And we establish a guidelines and we spread the idea of oligometastases, educating ourselves and the staff all over in the nation about the oligometastases, especially the presentation of a young. This is the highlights of management of oligometastatic disease we established 2 years ago. We try even to spread it even on the staff and fellows and everyone to have a better idea of oligometastatic disease. And thank you so much.
Thank you, Dr. Salem. Thank you, Dr. Salem. Please, Dr. Abdelaziz, the floor is
Thank
yours.
you. Thank you very much for a very interesting, informative presentation. I'm sure it will stimulate so many questions and comments. I think Dr. Sami.
Yes, please.
خلصنا 4 presentation. We're ready to questions.
Yeah, thank you. If you take it, because I have some technical problems. I am on my mobile because the laptop, I don't know what happened, but I have some technical problems.
Okay, so يعني خلصنا 4 presentation. We'll take questions now.
I don't see if
yes,
there is any question.
Yeah, okay. Any questions from the audience to our 4 speakers? I might start with asking Dr. Lulwa if she is still with us. Dr. Lulwa, you there? Okay. Dr.
السلام عليكم
Gulshan.
دكتور عبد العزيز.
أهلا. أنت معنا؟
ايوه معاكم بس على ما
Okay. All right. Now, I must say that I really enjoyed your presentation and the history, which took us from the 1970s, 50 years back. And as everybody sees that regarding the axilla and breast cancer, we are going from big surgery to small surgeries. We might end up later on by, as I said, by doing very minimal surgery or no surgeries. My question to you is regarding the targeted axillary dissection in post-neoadjuvant chemotherapy. First, are you practicing this yourself?
Yes, we are at National Guard. We initially started by doing wire localization, but it was difficult. Then we tried implementing the seeds, radioactive seeds, but there was some technical issues. Now we're practicing it using the refractor, the radio the scout localizer with the and it's like it's very smooth and like we are gaining experience, so it used to take us longer time, and initially we used to do it, we localize with the needle and the refractor. Now I use it without only the refractor itself.
Okay, so you think it will lower your false negative rates?
Of course, yes, absolutely.
Yeah. Okay. Are you making any statistics, any study, so that you can hear it in the future?
والله still it's an area of debate. We need number. We have to collaborate together and work. Yes.
Okay. I have a question from the audience to you, Dr. Lulwa. The guy who's asking said, I have a patient 50 years old, 4-centimeter tumor, multicentric, CN0, triple negative cancer, going for mastectomy and sentinel lymph node biopsy. She is found to have 2 positive lymph nodes in the. Is it reasonable to omit axillary dissection and give radiotherapy instead? I don't think this is a relation to your talk, Dr. Lulwa. It's regarding radiotherapy.
I think they want to omit the axillary lymph node dissection
and give radiation.
Yes, give radiation. This is a patient who is, is it a macro or micro mets? This is the question number 1. If it's a macro mets, I will definitely offer her axillary lymph node dissection. This is the standard of care. Even for micro and ITC, this is the standard of care. However, we are now more shifting taking away and discussing these patients in the tumor board, assessing like how's her, like how old is she, how aggressive does she want to go. Our radiotherapy colleague, they should give us their input. So, but definitely, if I will omit it, I will have a detailed discussion with the patient about the safety of omission, because it's not documented yet. And I think this is a question that will be answered by the TAXIS trial and Alliance trial. Uh, it will take time, but it will be answered by these two studies.
Okay. My second question is to Dr. Gulshan. First, we're happy to hear you, although you are across the Atlantic, but sure, inshallah, in the future, we'll see you in person in Riyadh. It's a common question that our residents here ask, and they want to hear it from you, that if you have a 5 centimeter patient, if you have a patient with a 5 centimeter tumor, and then taking the biopsy, the clip is inside the center of this mass, and then neoadjuvant chemotherapy started, this 5 centimeter tumor reduced to 6 millimeter tumor. How much tissue in grams and in dimension you're going to take when you do breast conserving surgery?
This is a really great question. Actually, going back to the previous one, and actually, I'd like to see what Dr. Bellin's thoughts were. You know, there is, I do agree 100% that an axillary node dissection is certainly the standard. But at the Brigham and Farber, you know, we were, you know, trying to extrapolate some of Amoros's data in settings like this, although this one probably, you know, we would have some concerns about radiating. What are your thoughts, Jennifer?
I'm sorry, I missed, was it 2 nodes after chemotherapy?
No,
or
I think it was straight to
it
surgery.
was straight. So, you know, 95% of the patients on Amoros had 1 or 2 positive nodes. And I think we would really try and avoid the toxicity of both axillary dissection and adjuvant radiation, which I would recommend in someone with 2 positive nodes and triple negative disease. So unless there was something very unusual, like extensive LVI and 2 very large nodes, I would lean more towards radiation and omitting the dissection to try and avoid the morbidity of both.
So I think that's, you know, something that's a little bit maybe different than what, you know, folks would hear around the world and in other parts of the US. But, and I wasn't trying to avoid your question, Dr. Al-Sayef. So it's, you know, when the tumor responds, sounds like really nicely in this case. You know, again, I would correlate the imaging findings. You know, are there, for example, suspicious microcalcifications that span that 5 centimeter area, yet there's only just like a 6 millimeter mass? But say the best case scenario is it was a concentric shrinking of the tumor to 6 millimeters. I'm not sure in grams I can correlate how much I would resect, but I would honestly just take the area of the of residual tumor plus you know, a rim of what we would consider normal. It could be, you know, treated tumor from the preoperative therapy with shaved margins, and then wait for final pathology. And I think if it was showed that there was no residual disease at the tumor borders, even if it was evidence of response, I would actually feel comfortable stopping and not have to remove that original 5 or 6 centimeters of abnormality. Yet, you know, there are cases, for example, like in the HER2 positive setting, if they don't get a complete response, often it's DCIS that is left. And in that case, I'd be much more hesitant and want to have more clear margins. And I think just as importantly, you know, we would then discuss this with Dr. Bellin or, you know, one of my counterparts here at Yale about their comfort level.
Dr. Gulshan, can I ask you, if you don't mind, Dr. Al-Sayef, can I ask a follow-up question?
Yes, please.
So I had a patient last week who had a large area of calcifications and HER2 positive disease, had preoperative anti-HER2 therapy, and had a pathologic complete response. And the surgeon did not remove all the calcifications and couldn't. So if they wanted to remove all the calcifications, the patient would need a mastectomy. Patient desired breast conservation. And because of a path CR, the surgeon felt comfortable leaving the calcifications despite in the setting of a PCR, and then sent the patient to me just to clean up in case there was any left behind. So there's a little bit of angst there. How do you feel about that?
Yeah, so this is kind of almost alludes to this question, is sometimes that you do achieve the path CR in the invasive tumor. And we know that the preoperative therapy is not necessarily meant to target DCIS. And that's where we get into a little bit of,
yeah, although there was DCIS in the core and there was no DCIS or invasive disease when they did the lumpectomy.
And how much did he or she remove? Roughly, like not in grams, but did they get like a
good sampling, good surgeon, yeah. But there's still calcs. In fact, they didn't even want to get a post-excision mammogram when I talked about it because they said, we know there'll be calcs.
Yeah, there will be calcs, but it may be good to know how those calcs would be then followed in the future with, if they suddenly increase or decrease. But that's the ones that I have the kind of the most discomfort with. Yet if the patient is, very much desirous of breast conservation, they know the caveats that, this is not an area we have great, data on, but it is reassuring that there was path CR even in the area that had both invasive and DCIS, that then going forward with radiation would make sense. I think, again, the safest answer would be, try to convince the patient of a mastectomy. But again, that's why we're doing these trials and these, we have these wonderful drug therapies and to push the envelope.
Can I extend the discussion further? Let's say that the patient is adamant and she wants conservation, and you are now following her, and an annual mammogram comes, and the radiologist doesn't want to take any responsibility. They will tell you these are malignant microcalcifications. Will you leave?
Well, what we can do is try to prove that it's dead disease by coring, if in 6 months or a year it's present and it's increasing, or they are still worried. And I wouldn't be surprised that it would just show, fibrosis and not active disease. So that would be a way to potentially ameliorate everyone's anxiety with this, is to after radiation and when they come back for their mammogram and it's still persistent, is potentially to core one or two of those sites. I don't know, Jennifer.
But I think you make also a very good point in that if she does have some residual disease and now you're in the post-radiation setting, and you could have potentially limited her options for reconstruction that you might have been able to do up front, right? Because now you're looking at reconstruction in the radiated tissue, so that's not as good. So I don't think it's so clear cut that we're doing the right thing here.
What I can tell you, what most of us here in Riyadh practice, is that we push for mastectomy, because it's a dilemma. It's every time you will get a radiology report and images, it tells you that these are suspicious or malignant microcalcification, and you back to biopsying it and back and forth. So I would try to push a little more.
I would too. But in the United States, and it's, in many parts of the world, the patients are, often will shop around till they find someone who's going to be able to offer them what, they potentially want. And of course, most will, listen and, work with the team that they have in. And I agree in your case that mastectomy would be the safest option.
Another question, Dr. Gulshan, regarding the retroareolar tumor which are strictly behind the nipple areolar complex. How do you look at them? What's your strategy?
I guess it's how close to the nipple area.
Very close, very close.
So, you know, for example, in the world of nipple sparing mastectomy, we were, you know, it originally wanted 2 centimeters, and then people have been pushing the envelope, and there are centers like Mass General with Dr. Smith and Dr. Laura Esserman at UCSF, where they often think of the nipple almost as any other margin, meaning that if you get no ink on tumor, you know, you would consider that to be clear. I'm a little bit more hesitant, especially in the setting of DCIS, in that area, because the few cases that I've seen that others have done, because I wouldn't offer them nipple sparing, was I've actually seen them recur as pageants of the nipple after both nipple sparing mastectomy and those that attempted breast conservation. Certainly, I think, you know, central lumpectomy makes sense. I think if we can get 2 millimeters, I'd feel more comfortable. And then again, this may be a case where, you know, if appropriate phenotype, give them preoperative therapy to shrink and then try to resect. It's a tough dilemma.
It is, yeah. There's a question to Dr. Salem. Dr. Salem, you're with us? Dr. Salem?
Yeah.
Dr. Salem?
Yeah.
Yes. There's a question from one of your classmates, Dr. Mutlaq al-Malki. He's telling you, how can we send patient to you for oligometastatic treatment?
Usually, all these patients, they have an access to our King Abdulaziz Medical City through patient's eligibility. Yeah.
Okay. All right.
Or they can directly contact me. We are available. Yeah.
Okay. So the rules are loose for those patients with oligo. Yeah. Okay. Great. Thank you very much, Dr. San. Very great. Thank you. Any questions to the speakers, please? I'm reviewing the Q&A. There are no more questions, and I can't hear anybody saying question. That brings us to thank you very much, our speakers. Very distinguished talks, very informative. Yes. Yes, please. Did I hear?
Just waiting for you to conclude, Dr. Abdulaziz.
Yeah. Okay, and we are concluding. I'm saying thank you very much. I thank my co-chair, Dr. Sami from Amman, Jordan. Thank our international speakers across the Atlantic and our local speakers. Thank you very much. We really enjoyed your talk.
Thank you.
Very informative.
Stay safe.
And see you soon in person after this COVID thing is over, inshallah.
I hope so. Inshallah. Bye-bye, everyone.
Thank you.
Inshallah. Thank you.
Okay. Thank you very much. It was an excellent session. So by this, we conclude our meeting. I would like to thank all our outstanding speakers, moderator. I would like to thank our sponsors and all attendees, and looking to see you in future meeting, inshallah. Thank you very much.
Thank you. Shukran.